Welcome back. I'm impressed, those of you who've stayed on, gold stars, conches. My name's Norman Swan. I produce and present the Health Report on Radio National and News 24, and I'm facilitating the next hour or so of your lives before you get to have an alcoholic drink, and which will just supplement the calories you just had sucking on that ricotta, which was rather nice. We tend to finish the day of these innovations meetings with an opportunity for you to discuss key issues. Of course, last year was surgical variation, and we had a bit of a debate on that. And today the issue is, whenever you do some healthcare planning, equity comes up. We'll have a little bit of equity, thank you very much. But what do we actually mean? And what we're going to try and focus the discussion on is equity of outcomes. Everybody goes on about equity of access, but access to what? To what end? That's what we're going to focus on with a really terrific panel. But before we do that, we've got several important announcements. One is somebody's mislaid their pocket Wi-Fi. I'll put it on the table here, and you can come and claim it. And somebody's lost a maroon iPhone. We haven't found it, but if anybody's found a maroon-covered iPhone, please let us know, and or to let us know at least what the plan was, and we can exploit it. No, let me. And a very important part of the proceedings is the announcement of this year's prizes, which for the first time have been determined by you with online voting. And the two categories are the best oral abstract and the best poster abstract. And I'm delighted to announce at least the best oral abstract prize has been won by Rosalind Rasuccia from St George Hospital for clinical trial refer, a mobile application to connect patients with local clinical trials. It's not quite the Oscars, Rosalind, but it's getting close. Well done. You don't get to thank your mum, but it's thanks very much, and well done, Rosalind. And the prize for the best poster abstract is Nasreen Kadden from Liverpool Hospital. Isn't it great you're still here? Wouldn't it be embarrassing if you'd gone home? And for incidence and extent of disease at diagnosis of cancer in the culturally and linguistically diverse population of South West Sydney Local Health District. Nasreen, and you're sharing it with Sandra.
Yes, sir.
Well done to you both. Thanks very much indeed. Bye-bye. We should have had a photographer here. I know that's what you're waiting on, but we'll do it later. So that's terrific, and we'll have those prizes again next year. The standard of presentations this year is extremely high, and it's fantastic to see, and it's about innovation, it's about improvement, and two great examples of that. So what are we talking about when we talk about equity, and what are the data? So the idea is to have as deliberative a discussion as we can rather than an opinion-based discussion. And there are some data around this. I mean, in many ways, that's in part what last year's discussion was about inequity in terms of surgery and outcomes. This year, it's much more in the broad. And so to talk about what the data show is David Currow, Chief Executive of the Cancer Institute, New South Wales. David.
Thanks very much, Norman. I don't think I need to convince anyone in this audience that there are differences in outcomes across the state that are not explained just by the disease. And that's what we're talking about this afternoon. Essentially, that's the definition. If it's not disease-related, what is causing difference across the state? And this is a snapshot that takes us through to the end of 2008, the last time the Australian Bureau of Statistics gave us our own death data. What I want to draw your attention to is the fact that there's variation. There's variation here by postcode. And so we need to understand that with that sort of variation, are there underlying characteristics of the population that help to explain those differences, or is it related to access to services? To what is it most closely related? And we have in the middle of that graph Northern Sydney with an age-standardised mortality rate dramatically different to the rest of the state. You've got a couple of large local health districts where their age standardised mortality rate is much greater than the rest of the state, and then you've got the far west with very wide confidence intervals because the numbers are relatively small there, but they're important for us to think about. So in the next 15 minutes, 10 to 15 minutes, just looking at these four factors as we consider the data that we do have to inform this afternoon's discussion. Let's start with an overview of cancer outcomes. We now measure cancer outcomes in what is likely to happen by the age of 85 because for the first time in human history we've had more of an increase in our life expectancy in one generation than really the last century put together. And that has been an enormous shift. 40,000 deaths this year. As we think about cancer in that setting, let's look at diagnosis, which is clearly out of order. I'm sorry, we'll come to diagnosis in a minute. What you can see here is that the absolute number of people diagnosed with cancer continues to increase rapidly. But if we look at age standardized rates, the blue line across the top, it's relatively flat. So what we've got is an increasing demand on cancer services in absolute terms, but at a population rate, cancer rates are remaining surprisingly stable. If we look at mortality, what we can see is that the gold line is actually decreasing. So again, although the absolute number of people that we're considering this afternoon is increasing, the standardized rates of mortality are decreasing really quite dramatically. And I don't think you and I have got that message out to the communities in which we live nearly effectively enough. Another way to look at that is to put those two lines together, and we see that they are diverging, that although the incidence rates are relatively stable, increasing slightly, the mortality rates continue to decrease. And that's reflected across improvements in every 5-year time frame since the early 1980s, right across the health system. But we've got all sorts of inequities, and the first of those is by gender. Which genes you have are clearly important in lots of cancers, but your 5-year relative survival, for example, is likely to be better if you're female than it is if you're male. That's not related to necessarily to the diagnosis you have or to the postcode in which you live. What about by age? What we've seen with age is, again, improving cancer outcomes across the population in all age groups except for the most elderly. And we can see that those people in the adolescent and young adult years, for example, come off a very high base and have continued to have improvements in their 5-year survival across the population. What does our 5-year survival look like? In 82 to 87, it was 46.9% across the community and is now sitting at over 66%. That is a massive change in a relatively short period of time. It's better diagnostics, it's better treatment, it's better prevention, it's not better prevention there, it's better diagnostics and treatment, it clearly is the impact in some part on screening programs also. What about by diagnosis? Again, we see that reflected across a number of cancer streams, that over the last 30 years, survival has continued to improve. And having said that, however, we see great disparities between cancers here, where pancreatic cancer is still has a very poor prognosis, as does lung cancer. We can talk about the orange bar in prostate cancer, but overall survival has increased across the board, even by cancer. What about by jurisdiction? We've benchmarked with 11 other jurisdictions, 4 from Canada, 3 from the United Kingdom, 1 from within Australia, and then 3 from within Scandinavia. How do we do when we compare our data with a single analysis? We deliver fantastically good cancer outcomes by any standards internationally. If we look at these data, we were number 1 amongst those 12 jurisdictions for colorectal cancer and in the top 4 for all of the cancers at which we looked. But look at the variation that we see across the world. If you have lung cancer, I'm afraid, ladies and gentlemen, you do not want to be in the United Kingdom today. With 8.8% 5-year survival compared to ours sitting at 17.6%. Likewise, you probably don't want to be in parts of Denmark for a couple of those other cancers. So we've got huge variation that is not explained by the diagnosis, nor arguably by the health system, given the similarities in the health systems that have been looked at. That's graphically looking at those data again and again. The important issue is, although we see improvements, we see wide disparities between countries in the cancer outcomes that are being delivered. I'd like to put this in the context more broadly of things including the social determinants of health. What do we mean by that? Where people are born, grow, live, work and age, the environment in which they live and particularly their socio-economic circumstances, together with whether they're from culturally and linguistically diverse communities or Aboriginal and Torres Strait Islander communities. I don't expect that we take in all of the detail of this afternoon, but there are broad societal features, socio-economic characteristics, health behaviours and biomedical factors that all interact across our community. And unfortunately, if we talk about inequitable outcomes, there isn't a simple solution. It'd be nice to say this is all down to access. And if we just built more centres in more and more isolated settings, we would solve the problem. It isn't that simple. And as we look at the social determinants of health, one of our challenges is that those factors really begin before birth and last explicitly to our grave. Although as a community we're becoming more educated and really quite rapidly more educated, with the number of people getting a primary degree or some sort of post-school qualification rising rapidly in the last 15 years, the real challenge is that our health literacy remains appallingly low. If we look at the summary document here, 59% are below the lowest level considered needed to navigate the health system. 35% are sitting at a level which will just have them navigating the health system well, and only 6% are above. When we talk about inequities of outcomes, we need to be very concerned about the health literacy and what you and I are doing as clinicians, policymakers, funders, to actually improve systematically the health literacy of our community. And if we look at that then by socio-economic disadvantage, with the least disadvantaged on the right and the most disadvantaged on your left, the real challenge is that health literacy predictably falls across those 5 quintiles. So as we think about trying to generate equitable outcomes, we have a lot of factors with which we need to grapple. And whether it's understanding the key facets of health literacy, whether it's across the domains of health literacy, there are major deficits across our community, and those are not equitably distributed. Health literacy hasn't impacted every stage of cancer control, be it prevention and early detection, presentation to health services, or the subsequent interaction with those health services for the care that is offered. What about the modifiable risk factors, the lifestyle factors? You know, the biggest risk factor for cancer is having birthdays, and we don't have a lot of control over that. But of the modifiable risk factors, we think about tobacco. Yes, we do think about alcohol, and we'll think about that at 6 o'clock this evening rather than 4 o'clock. Lack of physical activity and obesity, sun exposure and infectious diseases. When we look at the impact of tobacco across our community, it is huge, but again, it is disproportionately spread across the community. I'm looking at it by geography here, but we can look at it by socioeconomic disadvantage and see exactly the same sort of graph. So major cities have much lower rates than outer regional, and inner regional is sitting in between. Although we're very proud of smoking rates which are sitting in the mid-teens, we've got communities where we know those smoking rates are greater than 50%. Cervical mortality has come down dramatically since there was a national screening program. It is one of the great success stories of public health in the late 20th century. And yet we've got widely varying participation rates by geography. Again, we can look at this in terms of socio-economic status. We can look at it by any of the lenses we've discussed in the last 10 minutes. But the disparity is there in health behaviours, potentially leading to significant differences in health outcomes. If we look at that by socio-economic disadvantage, again, those confidence intervals are very tight. These are large numbers, and these are very significant differences across the community. And particularly when we go to very remote, for breast screen, we see a major drop, a drop of more than 5% in participation rates against some very good participation rates, particularly in inter-regional and outer-regional areas that actually trump metropolitan areas. So as we talk about inequities of outcomes, we've got various inputs into that equation that really do challenge us. If we look at Aboriginal and Torres Strait Islander communities, the incidence data are really quite frightening. But even more frightening are the mortality data. At every single tumour that we're looking at, there is excess mortality. And John Condon's work in 2005 in the Medical Journal of Australia was an absolutely seminal paper, because it blew away once and for all the thought that this was simply disease presenting later in this community. Stage for stage, Aboriginal communities across Australia have worse cancer outcomes. And that paper should have woken us up to the sort of figures we're seeing here. It is not just later presentation. So what are the most pressing systems level improvements in cancer control? What do we most urgently need to address? Ultimately, I'd like to challenge us this afternoon that if we can deliver the outcomes of the best of our performing services today, we will change cancer outcomes. It's not about silver bullets, it's not about anything new, it's actually about taking the knowledge we already have. We know those high-performing services, we know the outcomes they're delivering because we can now measure them. We now need to benchmark with those services, understand what the key success factors are, and replicate that across the system. Thank you.
Might as well go and have a seat. Thanks, David. Join us on the panel. And also joining us on the panel is John Emery, who's been introduced to you before today, Winthrop Professor of General Practice at the University of WA, but he's abandoning the West and heading for the University of Melbourne and joining the Victorian Comprehensive Cancer Centre. There's Eve Proper, who has been the Events and Sponsorship Manager for the College of Pathologists, but she's not here to defend pathologists, thank goodness. She is a very active consumer, being a survivor of Hodgkin's lymphoma, and was treated at Prince of Wales Hospital and is now on the board of the Prince of Wales Hospital Foundation, so she's controlling some money, which is good. Dee Delaney Teal is, as many of you know, is a proud Dunguti woman, born at Burntbridge Mission in Kempsey, and 20 years experience in community-controlled health organisations, and really passionate about self-determination in Aboriginal communities, and very influential on health policy. Raj Verma is Director of the Clinical Programme Design and Implementation at the Agency for Clinical Innovation here in New South Wales. He's been doing that for the last year or so. And prior to that was Director of Health Services Performance Improvement at New South Wales Health. Not sure where he went to clinical innovation because health service improvement was a hopeless task. I doubt it. Astrid Perry is really has been a frontline worker and thinker in the multicultural sector for over 20 years, currently working with South East Sydney Local Health District, and particularly interested in developing new service models for culturally and linguistically diverse communities. And last and certainly not least is Matthew George, Associate Professor at the University of New England, a medical oncologist with considerable experience and developing lots of fascinating models of clinical care in the rural communities. Please welcome our panel. So there's microphones here. We can maybe move them up there, maybe a little bit. Do you want to move them up a little bit so that people don't feel quite so threatened by having to come up to the front? The idea is you join in as and when you feel like it. Don't wait till the end. There won't be an end until we have drinks. So if you've got something to say on message, just come up to them. The beauty of having the microphone, just come up to it, and I'll bring you in. And that makes it easy for me to see you, and I'll bring you into the conversation. Because this is a conversation. This is a process. As David outlined, there are not going to be easy answers to this, but there are answers, and they're there for the taking. The question is, what are they, and how do we share this across the sector? So, Eve, just tell me what you've been up to as a consumer, trying to keep the bastards honest.
Well, I was going to start with a joke.
Right.
But I think you've stolen my thunder now. That the best thing you can do as a consumer is actually come out of your treatment and live. So that's number one. I think it's important, well, anyone who has gone through cancer will tell you it does change them, whether it changes them physically or emotionally, and does change their life. Yesterday I had someone telling me about monkeys in my head, which I found very disturbing. But I think it's important to give back and making sure that healthcare and access for everyone is accessible at the same level, and important in terms of patient transport. Can everyone hear me without the microphone?
Oh, you need the microphone.
I need the microphone, okay. So in terms of being able to get access to your healthcare, I think there's nothing worse than having to get yourself home after having chemotherapy if you live hours away. Being able to get on with your doctors and nurses. I have to say that my mum's in the audience. Isn't that nice support? See, she's going to get embarrassed now. There you go. And I thought it was important to try to get on committees where you could have a voice. So as you said, I'm on the Prince of Wales Hospital Foundation, which does not have as much money as you might think, Norman. I have to say that right now.
These suburbs are not freeing up their wallets.
See, now that's a very good opener that you've given me, that there is a preconception with the Prince of Wales being in the eastern suburbs that it is all eastern suburbs socialites that might go to the hospital.
It's not leaking from Darlinghurst.
It's not leaking from Darlinghurst, because indeed the Prince of Wales patients come from many rural and regional areas within New South Wales.
Tell me about your work on quality.
Well, it's only limited at the moment because I'm actually on a Cancer Institute New South Wales committee, which I've only been on for a very short time, so I'm not going to comment further because I'm not an expert in that area. However,
you are a consumer.
I am a consumer, and what I will say, it is very, very important when you are being treated in terms of quality to, one, know why you're being treated, to know what you're being treated with, and to have someone with you at the hospital at all times, because you are being given all these drugs, and I think it's really important to know why you're being given these drugs, why someone's dressed in purple, why they're in gloves, and what's happening to your body. And I think that is very, very hard because patients often, if they haven't got a bit of OCD and a bit of bossiness like me, become very passive because it's very scary what you're going through. So if someone says to you, you have to swallow these 20 pills right now, you'll go, okay, well, I'll do that. But indeed, I think the important thing is to actually give, and for patients to understand, to have a little bit of power and education to ask questions. Why do I have to take these pills, and what are they going to do for me?
Appalling statistics we saw there from David in Aboriginal communities in terms of cancer outcomes. What's your analysis in terms of the causes? Because there's no one cause, there are many. But if we could get down to the ones that that are more easily modifiable in the short term that we could do something about, what's your feeling about that in terms of how we change the way we do things?
No easy answer, Norman. But I guess I was just interested in the slide that was up there in the first instance where it said you can't treat everybody the same. And can you hear me? I would say from a clinical perspective, you've got to treat everybody the same. It's how you approach it is the difference. Whether when you're going into Aboriginal communities and so forth, or you're trying to get Aboriginal people to access services and so forth, and once they get in through the door or you get them there to start treatment, you treat them the same. But it's how you approach it to actually get the Aboriginal people or other people of other cultural backgrounds. You know what I mean? So you need to treat everybody the same, obviously.
Let me throw out a challenge to that notion. because it's partly about, well, do you actually invest the same amount of money and resources? Is that what the story is? Is the answer money? Because even if you were to invest the same resources as you do in South East Sydney, the whole health district, probably you actually need to invest more. And so that's the preferential investment. But then where do you place that investment? Because it's presumably not just about money.
It's not just about money, but that is a key factor. And it's about, like, I'll give you an example, the breast screening van that goes around. We probably need to do some more work in Western Sydney to get that van to come back out to our community and park across the road where we can get Aboriginal women from our community to get access to the breast screening units and so forth. I mean, it's about putting the services in the right place at the right time, in the right, in the right manner. So money is one factor, but it's not the only factor. You need to have really strong partnerships between, like our service is primary healthcare service deliverer, in partnerships with secondary, and that's the interface and integration of primary healthcare to secondary healthcare to tertiary healthcare as well, which is a really key thing. And we find that we get better access rates at our service when we have the specialists coming to our doorstep. So we run clinics, whether it's child and family health clinics, whether it's men's health or women's health, or it's even cancer screening and so forth. So we try to devise different ways all the time of how we can actually get people in through our doors so that we can provide the education, information to them so that they know that, I've got permission to talk about my sister because she's a survivor of breast cancer, and she picked that up through an opportunistic, a mammogram screen. Yeah, I'm not a clinician, I'm a manager. But anyway, so she picked it up through, just going in for an early test, and they caught it really, really early. So she only needed radiation therapy. She didn't need anything further than that. But the thing was, she's just an example of early intervention can really, really, improve your outcomes for a longer, fruitful life, hopefully. But and we're saying that to a lot of the Aboriginal women in our community, because she's now they were all very scared when she was diagnosed, and we just didn't know, and so we did a lot of research around it, and then we were providing flyers and everything. So we think that we've got a lot of our women in our community to go and have screening.
So Matthew George, given there's active attempts to reduce smoking rates in Aboriginal communities to deal with the lung cancer epidemic, but given that it's such a high-risk population for lung cancer, do you believe that it's justified in the Aboriginal, and it's not so much Torres Strait, but Aboriginal population in New South Wales, there's a case for CT screening?
Thank you.
As a way of addressing this inequity?
I don't have a data to support that, to be honest.
Well, it's a big randomized trial.
Well, I think if you say there are clusters of cases of lung cancers in this community, and majority of the patients are in a very advanced stage. So,
but isn't that the point of CT screening of high-risk patients who've been smoking, 30 pack years or 20 pack years or something like that?
I think there's evolving evidence coming at the moment, but at the moment it is not a standard of practice.
So, what's your position, David, on this? This would be a significant investment in a high prevalence cancer with huge mortality rates, and you would have higher numbers of Aboriginal people coming forward with operable cancers and being cured.
So at this stage, there's no national screening program for lung cancer anywhere in the world. As you point out, there's a study now with 55,000 participants that has shown a reduction in mortality for the first time, and that's exciting. It is low-dose CT. We haven't seen the sensitivity analyses for different pack year histories of smoking. So it was set at 30 in that study, but we haven't seen the data from 40 or 50 pack years. And importantly, we haven't seen the final economic analysis. There is no doubt that there was downstaging in this, and it's incredibly encouraging. I think what we can say today is that, that people with significant smoking histories need to have a much closer relationship with their doctor than we ever thought in the past. And I think there has to be a lower threshold for investigating far earlier and far more aggressively in people at high risk.
Would Aboriginal communities accept that, do you think, Dee? If you were to say, you know, there's a program available, you might even do it on a trial basis to see whether, because if Aboriginal communities, as they are starting to do, reduce their smoking rates, it's going to be 10 years before that flows, or 15 years before that flows through to changes in the data that you just saw from David.
Yep. Well, we're interested, and I've sort of had our services, and I run the research unit at our population health unit at Aboriginal Medical Service in Western Sydney, and I've had discussions with Sharon and let her know that we are interested in perhaps trialling that in our community. So we're sort of looking for different ways of approaching things, yes, so we would be.
John?
Yeah, I'd just like to chip in. I mean, I think it's really interesting, the data that have come out from the lung cancer screening trial.
Just bring that microphone a little bit closer.
But I think we do need to recognise the potential for harm because of the very high false positive rates. And that feeds not only into the health economic argument, but also if we were doing
so this
it
is
in...
finding nodules that you don't know the meaning
That's
of.
right, that require additional investigations on repeat CT scans. And if we were to focus it in Aboriginal people, and actually we may be creating potentially more harm by actually having a lot of anxiety from false positives,
But
lots
speaking
of
of eastern
engagement.
suburbs, I'm sure there are smokers in eastern suburbs effectively getting a CT scanning the same way as they're getting the PSA tested.
I'm sure there are, yes.
And they're having their lives saved.
Well, they may be having their life saved, yep. There's, as you say, a 20% reduction in mortality. But in terms of delivering it in whichever population that you choose to have defined as your high-risk population, whether it's all comers with a 30-pack year or specific groups.
So what's your track to improving outcomes in less than a generation in Aboriginal communities from lung cancer, in addition to stopping smoking? If you're impatient for improvement, you don't want this generational interruption. The West Australian Child Health Study, Aboriginal Child Health Study, showed that one of the reasons you get poor outcomes in Aboriginal children is that their parents die and their grandparents die, and people who look after them don't exist anymore. If you could interrupt that and have parents living another 10 or 15 years, you will transform the lives of Aboriginal children.
I guess the thing with that is that it's not just lung cancer. There are so many multiple morbidities and, in Aboriginal families that even if we were to introduce a CT screening program in that population, there are many other but more significant causes of premature death.
We'll come to the primary healthcare section in a moment. But Astrid, your take on inequities of outcome in culturally and linguistically diverse communities? I mean, it's not a uniform picture here at all.
No, not at all. And certainly in terms of smoking, we have some communities that have...
I'll give this one to Raj.
Also very... Oh, yeah, okay. that also have very high smoking rates, certainly in some communities. For us, it's not so much only about outcomes. We only seeing increase in certain cancers now as the communities are aging. I think that trajectory is really increasing now. However, we know quite a bit about access issues, health literacy issues, low socio-economic issues, so that whole social determinants interaction is certainly quite strong. But we also have the issue of stigma in some of the communities. So they don't disclose that they have cancer, they don't want the doctor to disclose that they have cancer to their family, the family doesn't want the doctor to disclose it to the patient. So we have relatively late presentations and under-screening in a number of communities. Of course, the communities they're not a singular community. There's many different culturally diverse communities, but we have a relatively good understanding which communities would find it harder to access services.
So in the New South Wales context, I'm going to ask an ideologically unsound question.
Yeah.
Which communities would you say have the biggest problems with health literacy, or is it just how how recent their migration is that's the issue rather than a specific community? What's the variable here?
There's a combination. So certainly people that came in their 50s, 60s often have lower English speaking ability for a start. Because there was no classes then, they went to work in factories and the people spoke their same language. So the manager, foreman and so on. So there's a lower level of language skills.
So this is the post-war migration?
That's right. They often migrated from rural areas because there was no work. So relatively low attendance at schools and so on. And then you have some communities that are relatively focused on their own community for a number of reasons. One of them, that might be religious reasons. And so there is much less engagement with the broader community, which also means often less engagement with services.
So,
yeah.
Go on.
And sometimes, it's also the lack of a GP that speak their language. Not that they always want to go to a GP that speak their own language, because sometimes there's fears about who is going to know about it. And we know of cases where the GP doesn't want to tell the truth either, and refers that to a mainstream organisation because the GP's reputation might go down in the community.
So give me an example of, it sounds to me, while I was deliberately provoking there over a high-tech solution with smoking, give me a sense, and I'm assuming that you've really got to take much more broad population-based approaches here, as well as individual approaches. Give me a sense of what you've seen working, whether it be here, other jurisdictions, or internationally, that you think we could learn from and apply. Again, on the same sort of theme as David was saying, is if we actually operated according to the best, we'd have an overnight dramatic improvement in outcomes.
Yeah. Pathways. Like my Aboriginal colleague was saying, we need to do things differently. We need to treat them medically the same, but we certainly need to support the communities differently to actually use services. And in most cases, that means a trusted bilingual person from their community that can actually make inroads and support them for screening, keep putting out messages, keep having projects with people, say for example, around smoking cessations, those kind of things. You really got to infiltrate the community and work with the community to make any change happen.
Do you think the health system is neutral to people from culturally and linguistic diverse backgrounds? Aboriginal communities would say it's absolutely not neutral, and there are health services which are entirely alienating and will differentiate the care they give according to ethnicity or Aboriginality. Do you believe they're neutral?
Well, they're probably too neutral. In other words, it's not effective. So if you
So they're not preferentially thinking about.
No, that's right. It's usually a single pathway, and it's usually this is how we do things. And then we'll have an interpreter if we need one. Most of the time, or a lot of the time, we don't have one because the carer is there, and after all, the carer can help out. And particularly in the area of cancer, that's actually very difficult for the carer. So really, we have a single answer for something that we need to have multiple answers, multiple approaches.
So tell me more about the multiple approaches, because then I'll come back to others in a minute. So you have an interpreter there.
Yeah.
You're not going to use the daughter. You're going to use a professional
ideally, that's it.
And invest in that.
Yeah.
Is that it? That's enough?
No. We actually know from some studies that we actually need to support the interpreter also. The interpreter can't necessarily culturally talk the same way as we as clinicians do it. So we really actually have to have a conversation around with the family and kind of exponentially work our way up to how much they want to know, how they want to approach it, how should we work with the patient, work with the family, who is the decision maker. So a much more complex conversation. And in our focus groups for our theatre project, in every one of them, they felt that health professionals were relatively insensitive to to some of their needs, not because they were not willing and supportive, but because they called a spade, for example, or they used scientific approaches to explain the cancer and so on. While some communities, the word is no go, the word itself is taboo. And they just sort of felt, look, they telling things to the patients that they never should tell. One of the key things was hope. Like it's not appropriate not to leave a patient with hope, even if they're going to die, in your opinion, in the next 3 days, or, you know, it's just not appropriate, because in many communities, you know, a higher being will decide when the end is the end. So as long as you're living, you should live in hope. And of course, we have this other kind of idea of disclosure, and we must let them know everything we know. So that's kind of two extremes, but that's kind of the shading that we're working with if we want to, you know, be actually patient-centred and family-centred.
So the investment of a service is in time.
Yeah.
So, and I assume it's very similar with Aboriginal communities. It's time. You can't be in a rush here, because communication is the essence, and you've got to have the right people around you to communicate. So it's resourcing those people as well.
Definitely.
Yeah.
How does that work? I'm I'm focusing on you two, but how does that work in terms of one of the key issues, which I think Cancer Institute New South Wales, and I'll come to Matthew in a moment on this, is that people in rural and isolated communities in New South Wales have worse outcomes, partly because their stage of diagnosis is later than it is if you live in the cities. And I assume that tracks through to Aboriginal communities and culturally and linguistically diverse communities.
Yeah.
How to actually come upstream so that people will come forward for care earlier in the course and consider it worthwhile. Dee?
I guess, like I was saying earlier, it's about trying to get, and I know, you know, there's only so much in the health dollar and so forth, but it's about trying to get the services for early intervention, early screening to the populations, rather than waiting for them at times to come to the doorstep, especially for Aboriginal people. And I mean, there's about 40 to 50 Aboriginal medical services across New South Wales. Community-controlled health services who are run by the community, in the community, for the community, and they're all at different stages. I mean, we're probably one of the bigger ones in Western Sydney. We do have a large population there that we do service. But it's about, like I was saying, it's about trying to get those services to the right place for the people to access it. For the example was the bus. I just wanted to talk about some of our data because of the ageing population. Australia is worried about the ageing population. Well, we don't worry about that because with our data, for example, we've got about 21,000 Aboriginal people in Western Sydney on our books who are clients. We've got about 10,000 roughly who are active clients who come to the Aboriginal Medical Service, and of those 10,000, we've only got about 700 elders, and that's anybody who is above 50. And the population there are basically very young. They're all young. So we don't have an old population. We're not worried about an ageing population. We're worried about...
you should be so lucky.
Yeah, definitely.
Matthew, give me a sense of what you're doing in rural communities to actually improve this, because they're much more diverse, your rural communities, than people think who live in cities. Having said that confidently that it's on, I'm not convinced that it is. It's not. You're going to have to share with Astrid. Sorry.
Thank you. I would say there should be three different approaches. One is a patient-oriented, a second one is a health professional-oriented, and third one it should be a community-oriented. In the patient-oriented approach, I think I agree. I mean, I think you people will agree with me. Of most important thing is establishing outreach clinics, and second thing is, as you all know, that health access is a major problem. So outreach clinic establishment is one of the most important thing. And second, as you all know, the tele and video linking and consultation over tele and video linking, and even family meetings. So I work in an indigenous community in Maori, and what we do is we have regular family meetings and discussions over tele and video linking. And those patients who are not able to attend the clinic in my clinic in Maori, and I used to conduct video linking with the help of general practitioners, even at the nearest hospital. So that makes very easy and to make the decisions very easily. There's one way. And second way is the health professional oriented thing. Thanks to the Cancer Institute for providing some grants for the primary cancer care, so which we divide into information, communication, and education. So it's really important in the community to improve the knowledge among the health professionals and communicate with the communication with the general practitioners and health professionals about the patient's journey, so they will understand that what is happening to their patient. And third, and the most important thing, is the community oncology. I think I myself would like to be called as a community oncologist rather than a medical oncologist, because I work with the community, I liaise with the general practitioners, I liaise with all the health workers. So I thank once again to the Cancer Institute providing me another grant, Aboriginal partnership grant, which is started.
We really haven't paid him to say any of this, Norman.
Anyway, we started that.
And when do the grants run out? Sorry.
So I think, that is a really interesting grant which increases the awareness among the community. So I think these should be the three fundamental principles in our...
Sounds great. You're getting better outcomes?
Well, I think time will tell.
Have you got any feeling?
I think it is. I think one thing I can tell you, that the primary cancer project, which is initiated by the Cancer Institute, it is showing a good response among the general practitioners. I would say many of the general practitioners who we have a rural multidisciplinary team, and they are trying to dial in and video link into that MDT, and they are giving you as a very holistic approach to the whole the patient. So it is quite interesting. It is warmly welcomed, and most important thing is that recently we started newsletters from the cancer centers, every 3-month newsletters, including what's happening in the cancers and the developments and what are things. So it's quite interesting.
I always remember a Robert Louis Stevenson novel, I think it might have been Kidnapped, where running up a set of stairs, and there's actually nothing at the top of the set of stairs, and he almost falls off. And so you create this demand. Where does the pathway lead? And if you defined it well enough so that you're pretty sure that once people come in through the funnel, they're going in the right direction, and the outcomes, all other things being equal, are going to be...
I think so. I think if we implement these things properly, and if there's a campaign...
So how much effort have you put into actually defining those pathways with enough granularity that everybody understands?
Everybody. I think that I thank to my director, Tony Priotor, for this outstanding support from the Hunter New England and providing the service. And we do have a fantastic service in Hunter New England.
Can I get a sense from the audience, how many think that you've got your pathways organised? That you could say exactly what the track is? Pancreas cancer, this is your track in our local health district. Lung cancer, this is your track. So people are shaking their heads.
Somebody up there.
You looked at your Whipples. What about before the Whipples, which is when you're diagnosed with the cancer? So there is a kind of a pathway to pancreatectomy. So defining the pathway, that's a huge issue for general practitioners to know their way through the system. What's the role of primary care? I'm going to come to Raj in a moment on this.
Okay. Do you want to talk about pathways first, or the role of primary care?
Well, why do you pick up pathways and then we'll reverse into general practice?
So some of the work that we presented this morning was around very clear fast-track referral pathways for people with symptoms that are more strongly associated with an undiagnosed cancer, and data from the UK experience of that model of a fast-track pathway that was very strongly implemented through a major implementation strategy. And I guess the evidence is that it works better for some cancers than others, and so it's not a cure-all for all cancers. The evidence is that you can reduce the diagnostic interval for colorectal and pancreatic cancer if you have these clear fast-track routes. But
so let me challenge you then on this, because it's fast-track into what? So if you fast track into, and people know who they are, you fast track into some local health district here, you'll get world-class outcomes in bowel cancer. Fast track into the local health districts, and they're not necessarily who you think, you're not getting world-class outcomes. So you're seeing the variation up there that you saw internationally, not quite, but you'll see it across New South Wales according to where you go. So it's great getting a referral, but if it's a referral into crap, what's the difference?
Yeah, so that's part about greater clarity of where where you should be referring for diagnostics initially, and then it's about how you triage those rarer cancers to the...
well, bowel cancer is the commonest internal malignancy.
Yes.
You know.
And, but we don't really know how much that variation is due to differences in treatments as opposed to later presentation or comorbidities associated with the socio-economic determinants of health that David is mentioning.
Raj, you're a signed-up member of the Lean Thinking Club. I mean, how granular should these pathways be so that people are boxed into a set of behaviours with minimum variation?
I think that's the root cause of all this.
Speaking of lean thinking, yes. Yeah. And speaking of lean thinking, you're going to have to talk into the
Hello.
lean microphone.
Yes, I'll choose this one.
I think they are working, it's just that you need to bring up the fader, so let's just, it should be on now.
Hello?
No. Go ahead.
No. All right. Testing. For me, it comes back to the data that Professor Currow showed, which showed variation in outcomes. And if we want to understand the variation in outcomes, you need to get to the root causes. And almost always those root causes are about fragmentation of your local systems. And if they're not designed to create a particular outcome, if they're designed haphazardly or they're just history, you will get poor outcomes, and the system is designed to deliver those and will continue to deliver those poor outcomes. So it's about how you deliberately design a system to create the outcome you want. And in cancer care, it's very much about how primary care, the specialists and general hospitals, emergency departments all work together, including screening. So you can have the shiniest machine that does diagnosis, but if you've got a system that doesn't pick up people, you're wasting your time. If you've got the best drugs and the best radiotherapy, if you're not getting people engaged with the right supports to build trust in the system, then you'll get the variation in outcomes.
So is it as simple as saying we just give clinicians too much freedom?
There's a little bit of that, but it's no.
Only a little bit?
I think it's about deliberately building a new system, and we're not good at that in health. We love our autonomy. The more senior you are a clinician, whether you're a doctor or a nurse, the more you know about a particular thing, and because you're an expert in that, you think you're an expert in everything. And so when we try and diagnose root causes of poor outcomes, it is a real eye-opener for people when they go and talk to patients and carers and other providers about how poor the systems are.
So tell me how you would take up this challenge that David presented, which is that if we all performed at the level of the best, and I assume there's variation according to tumours, some are good at some tumours and others, so it's not, we don't have uniformly poor outcomes in local health districts. It's some tumours do it better than others. How would you just give us the way through for people in the room, assuming they've got the data on outcomes, which is a big assumption?
Yep.
How do they then go into a redesign process which brings everybody up to the state's best?
I think the one thing that I know in health, people jump to solutions. I have the answer, just give me some money and we'll put it in and we'll do it. So our most important part of the project is doing a good diagnosis. And by diagnosis it means walking in the patient's steps, actually mapping the patient journey, talking to carers, talking to patients, talking to the referrers about what worked and what didn't, looking at the local data about what things go wrong, where there's waste and duplication in the system, where the system is completely fragmented. And we see that over and over again in chronic care and cancer, is that the patients and the carers are the navigators because no one in the system takes responsibility to navigate or even create a system. There is no system. There are just multiple service providers. So it's really getting that on the page, getting everyone on the same page about what the problems are, and then together they will develop smart solutions.
So you can't just go and look at the high-performing system and say that's going to apply to us?
No, every community is different. There'll be some characteristics in the high performers, and we love going to see high performers, but you have to localise your particular solutions, because you will have different primary care, you'll have different diagnostics, you'll have different community groups, so you do need to localise it. There will be some principles.
Which are?
There'll be principles around how you join up care, about there'll be some clinical practices which should be minimum standards, and there'll be keeping the patient at the centre of the system.
And there's going to be some new data points, are there, or is that not always the case?
Quite often there will be, but in fact I don't think it's just about the data at this stage. It's really understanding the system and then agreeing to build a new system.
And that can take many months.
It can, years even.
So don't be too impatient, the way I was about lung cancer deaths in the Aboriginal community.
You can't turn around a 20-year problem in 2 minutes.
Damn it. So what's the role of primary care here, John?
Well, when we were talking about the social determinants of health, the notion of the inverse care law, which has been known about for a very long time, which is essentially came out of looking at variations in outcomes in Wales and access to primary care there, which showed that those who were most in need of care had much poorer access to primary health care. And there are two really major systematic issues in the Australian primary care system that feed into this ongoing inverse care law that is contributing to poorer outcomes, and particularly in those in the groups that David mentioned. One is to do with the way that we set up general practice systems, in that if you're a locally trained GP, then you can choose to set up shop wherever you choose. There's absolutely no control at all about where you actually choose to practice. And so inevitably, we have oversupply of general practice in better off areas and undersupply in the areas where actually there's much greater need, and whether that's in outer metropolitan areas, in rural areas. So that's a major structural contributor to poorer outcomes, and but is one that most governments are probably too scared to tackle.
So there's that.
And then the second, which relates to time, in that we currently have a model of funding that in general practice that actually disincentivises longer consultations. And so people with these more complex healthcare needs, what they need are longer consultations in general practice, so that you can deal not only with their acute problem, but with their preventive issues as well. But actually we have a Medicare system where, particularly in practices where inevitably you're bulk billing, then the only business model is to be having frequent, short consultations, because that's the only way you can run your business. But actually what we need is a system that incentivises longer consultations.
So how's a state-based organisation to create foci of change?
I appreciate that these are federal issues, and but they're structural problems that are contributing at a primary care level to these inequities.
David, I mean, isn't there an opportunity to actually create new models of primary care and just say, well, look, if I'm going to face federal state differences, this is so important, we'll actually create a model of bundled payments and see what happens?
I think there's a fantastic opportunity to create new relationships, Norman, with Medicare Locals, and to understand that Medicare Locals form a new paradigm in terms of taking forward integrated care in primary care, not just medical care, but across allied health and nursing in a way that people have dreamt about for a long time, and some Medicare Locals are starting to operationalise that. I think our ability...
September 7th.
What's that?
Until September 7th.
Certainly until September 7, our ability to use those relationships strongly is looking very bright. I think it's not about who funds it, it is about how it's funded, because that's where the levers are for incentives and disincentives. But there's no doubt that we are starting to form good relationships with Medicare Locals with a view to really changing some of the fundamentals that you've outlined today.
Raj, when you develop, you've done your lean system thinking, you've done your root cause analyses, you've walked the kilometre in the patient's shoes, in the carer's shoes. To what extent is then is health system literacy an important issue, so that consumers independent of everybody else, know their way through the system? And how might that work? What sort of model, if it's important, what are the models of actually transmitting health system literacy which go beyond the crumpled brochure in the GP surgery?
Yeah, well, it's an exciting time. It is important, and I don't think anyone would argue against that. And people are doing it now through their crumpled pieces of paper and through friends of friends and who we met, and a brochure you picked up at the medical practice. But the time is ripe for the new technologies, online contact centres and registries of service providers, linking up primary care and acute care into one spot electronically where people can get referrals and escalate when things are going bad, and try and keep out of the acute system as much as possible. So there are opportunities. I can't say that there are a lot of them here at the moment.
So Matthew, to what extent are you able to box consumers into a pathway which minimises variation along those lines that we've just been discussing?
I think the oncology practice is different from the routine general medicine practice. So we always take into consideration of the consumer, and that's the most important thing. So when we talk to the patient about a diagnosis or treatment or follow-up and everything, it's basically patient is the most important thing and not the doctor. So
but if you don't know as the doctor what the pathway through the system is, what the
well,
heck are you telling
I think
people?
that's a tricky question. So we know how to manage this and properly guide it. At the same time, we take into consideration their views are the most important thing.
Sure.
And then we can guide them.
But do you believe that you've defined the pathway well enough that you can communicate?
Well,
this is the way through.
I mean, there are different mechanisms in which we can communicate. So there are issues when we have different problems in communicating things. We always take the help of other people, social workers, other people, in to make it very convincing or make it very clear. So, for example, one thing which I notice in my practice is that when you see an oncologist, they talk about so many things, like this is the scan, this is the diagnosis, this is the way to be treated, blah, 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 20 minutes. And but 20 minutes after consultation, doctor thinks that everything has been conveyed, but patient has no understanding about what has been conveyed to this. So what...
They remember one word,
cancer.
Yeah, that's right. So what I do, I think it's in my life, it has changed a lot. So I take a big piece of paper and then I put his name on the top and started exactly right to be more legible, not like the usual doctor's scripts, and make it very clear, flow charts, and then this is the record, you can keep it.
So you
give it to them,
a written
and
version of the...
give to them.
See?
So that makes a lot of difference, and they will not go around and tell them that Matthew told something else which we don't understand.
I mean, that's a huge issue, isn't it? Knowing your pathway and trust. So one of the things that people say increases quality and safety is having a buddy with you, rather than relying on the system providing, having somebody else with you.
Sure.
Do we do that enough with Aboriginal communities, actually recognising that family member, friend, member of the extended family or tribe being with you and actually accommodating that?
We don't have tribes, Norman. You told me to be funny earlier. I thought I'd throw that in. We do, with our Aboriginal health workers, I guess, we do buddy up. And, you know, if we know that people do need to go to specialist treatments through the hospitals or wherever, and they're not going to show up, well, we get our Aboriginal health workers to track them down and take them. It doesn't always work, but there are trusted Aboriginal health workers in our communities that if Auntie Joyce comes looking for you, well, you got to go. But I wanted to sort of come back to that.
We want some Auntie Joyces for the rest of the system, please.
Yeah, we need them. I mean, you know, she's an elder in our community. She's been a health worker. She went through the first cohort back in the early 80s here in Redfern. But I mean, we're lucky to have her now. But she's had a couple of bouts of cancer herself. I wanted to come back to those incentives from the primary health care, because we have done a lot of work in Aboriginal health around preventative guide to health assessments and so forth, and we do have two very good MBS items, and that's one for an adult health check and one for a child health check, and they're pretty comprehensive. They, not just medical, but look at social determinants, whether people have housing issues, social emotional wellbeing issues, drug and alcohol issues. So it picks up a lot of things. So it takes about 40 minutes.
You use them as an opportunity to create time as much as anything else.
And we get paid for it. So I just thought I'd...
To what extent have you bundled payments and salaried? When Redfern started, the GPs were salaried. To what extent have you managed to bundle payments so that you get beyond this hook on fee-for-service, which tends to mitigate against the sort of care that John was talking about?
We still salary all of our workers, but often they get poached, especially when we, educate doctors who come into our service. We do have some who've been around for a long time, but it's hard for us. We don't have a full-time GP just in Western Sydney. We have got about 12 FTEs filling about 5 spots. So we can't get a full-time GP in Western Sydney. I know we've got lots of troubles getting them out to rural and remote areas, but when I tell people that, they're like shocked. Well, how come you can't get a full-time GP? And I'm like, well, I don't know. But we do bundle up. Everybody at the AMS are salaried.
So I want to hear from you now. This is a huge challenge for you sorry, Sancho coming in. But while Sancho's talking or making a point, is how do you in your services create those pathways? And what do we do about the private sector? Are there such things? And can we actually track people through the 60% of the system in some areas that's private? Sorry, Sancho.
Yeah, I really wanted to pick up on the kind of models of care and the system issues. We heard this morning about my trip to Burke last year, and it really did impress me. But one of the issues was one of the GP clinics outside of Burke has had 110 GPs through the 3 positions in 12 months. So we're we're relying on a medical model of care in that case for the most vulnerable group of patients in our community, and yet we don't have a system that actually says this is a system issue where we can't actually build it around the GP. We actually need something else to fix it. And yet at a Medicare local level, they get a little bit of money for coordinated care, they get a little bit of money over here for something else, and none of that, it's all piecemeal, not systematically addressing the issues for that community. And I just wondered what the panel, whether they knew of solutions to some of that, and how we begin to really develop system responses to the needs of a community rather than just use the models we already have in place.
Raj?
Yeah, I don't have an answer, but we will keep coming up with piecemeal solutions until the funding incentives are aligned and until the Commonwealth and the states get together to say we want to manage this group of people well before they get sick and not have really high-class chemo and radiotherapy as the only resort, not the last resort, but the only resort, and you wait till people are at that stage. So we will have local pooling of funds. I've got no doubt within the next year or two that some Medicare Locals and some local health districts will get in and pool some funds around some groups of patients, and it'll be fantastic. But it's a piecemeal approach that is high risk, that takes a lot of time and investment of senior people to sign up to it, and that'll achieve something. But until we get a bigger picture, it's going to be very difficult to get broad solutions.
So, Eve, unless consumers come around this and lobby, and politicians feel there's votes in this, so we're talking about systems change. We're not talking about a new scanner. We're not talking about more PET. We're not talking about targeted therapies. We're talking about system change. To what extent do you believe that consumers should and can be mobilised to this sort of end?
I think consumers should be involved on a very high level, but the problem is that a lot of consumers, when they get to the end of their treatment, are just buggered and just want to escape and not hear a lot about it. And I suspect that's what you'll find if you survey a lot that have gone through the treatment. They've just had enough. And depending on their pathway, they're just sort of over it, quite frankly. A lot of patients I met just wanted to have their treatment and then never see another doctor in their life.
Yes.
Hi, I'm a GP, and I wanted to pick up on...
Have we got a job for you?
Yeah, several by the sounds of it. Not sure whether to go to Broken Hill or Western Sydney. But I wanted to pick up on the comment about pathways. I think this is really crucial, and I don't know what the answer is, but I'd maybe like to put Raj on the spot again about to expand some of his ideas on systems change. A typical scenario would be that a patient who is most likely to have cancer will be a squeezed-in appointment at the last minute because they've woken up that morning with rectal bleeding, or because the radiologist has phoned to say, this is a suspicious mammogram, can you squeeze this person in after lunch? I'm sending them straight to you.
As a GP?
As a GP, for discussion about appropriate referral. So you've already got a waiting room full of people. You know this. Your heart is sinking because you know this patient, they might have cancer. They're obviously, coming in with fear all over their face, maybe with a relative. And we just have this old-fashioned system where we go through our directory of local pathologists and we ring and beg and plead the receptionists to squeeze them in for an appointment as soon as possible. With the patient sitting there, and it's just a horrendous thing for everyone. The receptionist feels put upon and stressed. We feel terrible and inadequate. The patient feels, and their relative can't believe this is the system that we have. And I'm sorry to be so blunt about it, but really I think any other GPs in the room would probably say we've all experienced that far too often. And it's just really sad. I just think in this day and age we can do better. So I wonder what people think about that.
I think that's a clear manifestation of a lack of a system. There is no system. It hasn't been designed to cope with known, predictable events. People will have escalations of their condition that need to be managed. And in fact, over a year...
And we know how many, we know when.
You can guess, you can estimate, not guess, you can actually do stats on this and know, over a course of 6 months it'll be 4 times, it'll be on particular stages of their care, and they'll need X, Y and Z. And you can actually build systems to predict that. It takes a lot of effort and a lot of work, but you can do it. But no one's even starting to think about doing that because I'm a GP and I'm funded this way, I'm a district, I'm funded this way, I've got my little bucket and this is what I'm going to do.
David?
I was going to make the point, we can predict exactly who's going to be diagnosed with cancer on Monday. It's just where they will be in the state at the time that happens, and I think we need to stop being surprised. We've had a population-based registry for 40 years, it's the oldest one in the country, and we now need to start to plan for rapid access for that care so that people can move through a diagnostic pathway. I think John, however, illustrated perfectly this morning the challenge of that our positive predictive value really will run at somewhere around about 10% for those rapid access clinics. And so that's a challenge for a health system that has no funding model for that at this time. But we really do need to get over the surprise of how many people will be diagnosed with esophageal cancer in the next 12 months because it is absolutely predictable.
And John, you opened the discussion up to a broader system change in terms of incentives and payments for GPs. But I mean, how many people in the waiting room actually need to see you?
Well, I think that's part of our problem with a fee-for-service model is that you generate demand, potentially. I mean, we know that if you look at different ways of funding primary care, then you get what you pay for. So if you have an almost entirely fee-for-service driven model, then you tend to create demand. If you have one that's almost entirely capitation-based, you reduce demand. And if you have one that is got elements of payment by performance, then you limit what you do to the things that you get paid for. And we need to think about what the pros and cons of each model are. But I think at the moment we have some incentive payment models, but they're very limited. And most of the time we're driven by a fee-for-service model that in some circumstances may be generating unnecessary demand.
Yes.
Oh, hi, my name's Jeanette. I'm a social worker from Westmead Hospital. I'm actually just wanting to say that with the people that I see through the cancer centre and also on the ward, is that a lot of them are actually from different cultural backgrounds. I think we have about 13 significant different cultural groups in our Western Sydney area, and we also, as a hospital, have the highest use of interpreters. And our main problem when we see people is often they're actually, it's access plus it's engagement. Firstly, they find access to services really hard to negotiate and understand. Often they come from cultures and countries where our formalised system,
Can I just ask you a question?
Mm-hmm.
Do you understand your service?
No, I find it complex too. I find forms complex, I find systems complex.
And your boss is standing behind you.
I know.
I'm going to ask him whether he understands his service in a minute.
But I suppose my question is, it starts right at the primary level with we find with our GP. A lot of them don't have a GP, or finding a reliable, regular GP is difficult because of the Medicare system. They're either not bulk billing anymore, or there's a gap payment, or they're not taking new bookings, and often they're not being interpreters not being used when they're going to GPs. And then when they're coming through to our system, we're required to use interpreters, but it's a fairly formalised interview or a session that we have with them. And then also they then move on to a fairly fast-track medical process if that's what's needed. I'm just wanting to know, in terms of the panel, what we can do better for these cultural groups and people who come from different backgrounds, and even our Aboriginal sisters and brothers, to assist them with the process, because that's why I think they're having the highest, the lowest presentations and the highest incidence of sort of terminal cancer because of the system.
Astrid?
Well, we've lost a lot of investment in the communities. I think I've got to say that. So at the preventative end and at the supporting end, we've lost a lot of migrant workers over the last 10 to 15 years. And I think that has made a big difference, because people can't go to their local ethnic organisation and talk about their problems, or say, look, I'm scared about this, will you come with me? Or, we have Aboriginal health workers, which is lucky, and we have Aboriginal owned health services that the community owns, and we've lost a lot of that in the migrant sector, so that's a starting point. I think the whole trust issue is a big issue, and I think people do need more time, and we really need to build capacity in the community to support the people, including our volunteers in hospitals. And it takes time and it takes effort. So if you could offer to that Chinese person somebody that can help them with the fast tracking, even though they're a lay person, it would make a big difference. And I've had a conversation this morning with somebody in the audience from the previous session who said she works in allied health in Westmead, and the people are disclosing to them, saying, I'm scared, where should I go? I can't talk to anybody about this. And I thought that was very interesting. People are looking for support, somebody that they can talk to. And they don't necessarily talk to the doctor.
Dee, and then Matthew, and then I'll come to David.
Yep. It's about, look, I've visited people, Aboriginal people who've been in hospital, when they've had cancers and so forth, and it's a pretty daunting, it's daunting for anybody, but when they're not understanding some of the language that's sort of being, told to them about what they've got, what their treatment is and so forth, I often have to sort of, go and sort of talk to the doctors or the nurses and say, well, can you just go back in there and explain, to them in a bit more of a layman's sort of language. I mean, I understood what they were saying because I probably work in health, but I'm not a doctor or anything like that. So some of the stuff went over my head. But at the occasions in the last couple of years that I've sort of been in visiting people who are Aboriginal in the Penrith and Westmead, well, it's just so daunting for them, and they don't understand. And we had one lady who actually just sort of left her treatment and just went back home because she just basically didn't like the treatments and so forth. And
so the solution? The
solution, look, there's probably not one single solution, but I suppose it's about trying to develop. Somebody even told me that they wanted to have some sort of a book. This was a person who had cancer, and it'd be really good if there was a layman's sort of a document or a book.
She needs to get Matthew to draw it for her.
That sort of told them what to expect, throughout the journey, because there was sort of nothing available.
Matthew?
Well, I think I worked in Darwin 4 years with indigenous people, and it's quite interesting. I mean, it was a really difficult task to explaining the medical terminologies to the people. We use a lot of, there was a book I still remember full of pictures, and we were trying to explain based on the picture diagrams and then explaining one by one, and we used different methods. Actually, the picture method was the best method I used, and it really worked in that place. So I think it's so difficult.
And
there's no
Alan
solution.
Cass in Darwin showed that, in fact, even with Aboriginal health workers, given the cultural diversity within Aboriginal communities, it didn't guarantee you good communication if you had an Aboriginal health worker, because they didn't, David, do you want to make a comment?
Oh, look, Westmead already had the solution. We just need to clone the late Dr. Tony Bahaja. Doing ward rounds with him was frightening, because he'd switch from Arabic to Italian to French.
At least that's what he told you.
Well, that's what he told me. Patients seem to be communicating with him.
Paul?
My name is Paul Harnett, and I've been working in cancer in Western Sydney for almost a quarter of a century. And I'm sitting here getting depressed. But I wanted to sort of have an observation and a comment, really, because it's very easy in these sorts of discussions to have absolute truth in what we say, but sort of depress ourselves a lot too. And having been here for a long time, I can actually say I remember when I arrived in 1990, did the first clinic I ever did out there, comparing to now, and it's a lot different to what it was 25 years ago. The first few weeks there, I can remember the first patient I ever saw. The first 3 weeks I had nobody booked in my clinic. I thought, oh, they don't need me, this is a waste of time. And then I got a ring from a GP saying, I have a lady with metastatic breast cancer, but there's any point in referring her to you because there's not much you can do about that, is there? And that's 1990, that's not a long time ago. Then the clinic started to build, and people used to talk about referral patterns and accessing the system, getting to see the right people and so on. And there are methods you can do that aren't the solution to everything, because we're dealing with a really complicated human problem with all of the things that go with all the problems of humanity. But there are components of that you can do that do work. And one component of that is we have found, and it's not perfect and it goes wrong every now and again, and every day we have to deal with individual instances where it's failed, because that's life. But the backbone to the system that does work, I think, in a tertiary referral setting, which is what I'm talking about. I'm not talking about rural areas and everywhere else. My experience is in that setting. You can get together a group of people, doctors and nurses and pathologists and others, who are really interested in one type of clinical problem. Not just sort of doing it for a living, but really interested in that sort of clinical problem, and say, you're the group that sort of owns this problem and develops this problem. And over time, you get a group of people who are really interested in it from lots of aspects. So people start to become interested not only in the service provision, but how do we compare with our competitors? Or they see them as competitors. Are we as good as the others? Are we researching this the way? Are people accessing our service properly? And you can develop a team around that, which is more than just a meeting. It's a program of sort of making sure the right things happen. It doesn't always work all the time, but I think a component of the solution in a place that's adequately resourced to do that is to focus on having teams of people who feel like they're really interested in dealing with that problem.
But are you approaching it in the systematic way that Raj is, the challenge that Raj is throwing out, that is systematic, analytic, and quite granular?
I think it's a thing that you have to keep working on forever. You have a few teams who take to this and do it really well within a few years, and they quote to me the statistics about their waiting times and their outcomes and those things. And then over a few years, some of those personnel change and move, and others move on to do it. But what we have been working in recent times on trying to take the next step with this by defining what we have agreed in ourselves is what we regard as a high-performing team. And by that, they're people who are not only just triaging patients and so on, and not just having agreed protocols, but monitoring outcomes, monitoring waiting times, what research are they doing, what health services research are they doing, things of that kind, to try and foster the idea that there is more that you can do with this particular vehicle in the system.
So if you take a population approach, Paul, what responsibility have you got for the private sector, given that there's some excellent things that happen in the private sector, but there are also some appalling things that happen in the private sector. It's appalling things that happen in the public sector, but in terms of overuse of chemo, too many chemo courses, too much use of diagnostics. People are turning it into a business, and it's not necessarily for patient outcomes. If you've got a responsibility, in a sense, for a population, to what extent do you integrate the private sector into this story?
The way it works and what's worked for us, and I guess we might have been a bit different to some other places because we were all new when we started there, was that people who work in our system might have also work in private, but they belong to these tumour programs. And so they will present their cases as well. And the ethos is we all present the cases, and the biggest factor upon bringing practices more in line with everybody else is just sharing what goes on, openly talking about it, rather than arguing people and telling people to do something differently. If you show that this is the way everybody else is doing it, people start to normalise it works as well. So we have very, very little private practice in our part of town that is not linked into the actual cancer service.
Thanks, Paul.
One other comment I'd like to make. We made public to our GP colleagues years ago a directory of services to say these are the people who have a real interest in breast cancer or lung cancer or gynae cancer. We didn't say, don't send it to this person, and we didn't say to somebody else, you can't be part of, you must stop operating on 2 breast cancers a year. What we did was made it known who we thought were great people to refer to, and that started to reduce the number of sort of referrals that weren't to necessarily the best people. And one last comment I'd like to make about negotiating the system. Again, I agree with everything that's been said, and I've had family members, and I've been in hospital, so you know exactly what it's like and how terrible it can be. But part of it is actually just good clinical practice, which I think is slipping a bit. And that can be as simple as saying to the person, this is what you do next. This is the person you see next, and that's what they're going to tell you. And the fact that you'll see people many times during their cancer illness, and you go over and over and over it again because no one remembers it all the time. But I worry about...
So in the sense that you rehearse the handover with the patient?
Yes, and I don't think that's necessarily a new technology. We don't need an army of people to come around to implement it. We just need to get back to some of what used to be and has always been good clinical practice. And just teaching that to our junior staff and emphasising that.
Can I just reinforce that? A lot of our people say, they taught me a whole lot, now what? So it's really important to say at the end, and this is the next step, they will review within the next week, for example. Because we do tend to tell everything in one go, and as I said again, that open disclosure stuff has really brought some of that about, I think. And then they go out like you said, no idea at the end of a half an hour. So you really must come back to what is the next step, so that people are very clear about that.
Thank you.
Thank you.
One question is, you can have tumour groups or tumour-specific treatment groups in a big city, but a person like me and a community oncologist, but I'm the person who sees most of the cancers, lung, breast, colon, melanoma, everything. So actually what is happening, the community oncology, I think I would say, I use the local resources with the help of secondary and tertiary centers, and then we will guide the patient. Or for example, we have our own tumor group for a breast to be a difficult case, which I find it extremely difficult to manage. I'm not an expert in that area, probably I will present in a tumor-specific breast cancer MTT or like that. So that I'm sure that that will give you the correct guidance and treatment for a particular patient.
Thanks very much. And final comment, we're actually going to be able to take the last comment.
Okay, it's just a question actually. We started the talk today talking about social determinants, and you raised the really important issue of health literacy. David, my question goes to you, but to the rest of the panel as well. Do you really think that our current best systems provide good outcomes for people with low health literacy? Or is this actually an issue that we have to improve the capacity of even our best systems to deal with?
David?
Always have to improve on the best. We've got capacity right across the system to improve what we do, and we need to be systematic about it. I couldn't agree more strongly with Raj. At the end of the day, every system can improve. And to take Paul's point a step further, every system is a living system because it's made up of groups of people. And they all have life cycles. Every team has a life cycle, every service has a life cycle, every institution has a life cycle, and we need to tap into that, understand it, and use it to drive improved outcomes.
John?
I'm not sure I can add to what David said, really. I think it's a very good summary. I mean, I think, yes, there's always opportunities to improve, even...
But I guess my question is, do we have enough evidence about how to improve services being delivered to people with low health literacy, which we identified as the critical factor?
So
do we know how to do that well enough, or is that one area that we really need?
So you should look at the Ophelia project in Melbourne. Richard Osborne's, that's what they're doing now, is actually testing ways of actually delivering improved health literacy. And there's quite a lot of investment going into that. Ophelia, if you could Google that, or listen to Monday's Health Report.
And
timing.
You didn't even see that advertorial coming, did you? I mean, you know, one of the papers that I love to quote was from James Tulsky's group at Duke in North Carolina, and they got a New England Journal article out of this. What did they do? They watched a summer's worth of television in the United States. They watched ER, they watched Chicago Hope, they watched House. House?
Yes.
Yes, thanks. I've never watched it. You can tell. MASH was my CPD. But they actually...
House was very realistic. You know, a drug-addled doctor who made the most remarkable diagnoses.
Perfect. I mean, it's replicated time and again across the world. But the interesting thing from the New England Journal article was how it treated the issue of outcomes. It was doing nothing for health literacy because everyone miraculously came back from the grave because they had brilliant diagnoses made by a drug-addled doctor. So we're not actually helping our health literacy through you know, our popular media, for example. We're creating very unrealistic expectations as technology goes forward. So the issue of health literacy is really quite challenging across the community. Raj?
I was just going to say, it's all the media's fault.
Absolutely. Although Harvard School of Public Health used to have an annual scriptwriters conference.
Yeah.
But I don't think they do it anymore.
And if you look, actually, Johns Hopkins, I think, is the clinical advisor to House. So I mean, it's not as though they're not getting any advice, but they're getting advice from quaternary centres that may not provide the sort of reality in which you and I live.
Yeah. Could you please? So you can call it the impotence line, do you? So you it's a very good point, that there are resources which we could use better and expand.
Yeah, can I concur? They are an excellent resource. I did, not just for the patient, but for friends and family, and all wards do have them in there, and they are very, very well produced.
And just for the record, I carried their library on my race car for 6 straight years.
Mm-hmm. Could you please thank our panel? And can I invite David Currow to close the meeting?
Ladies and gentlemen, I won't stand between you and an afternoon drink on a Friday, but I'd like to thank each of you for participating today. Today is about how do we improve cancer outcomes, and I hope that, as I said at the outset of the day, that you will take back with you 1 or 2 ideas. It was fantastic to see presentations today that were ideas germinated last year that have grown over the last 12 months and been turned into systems change as a result. I'd particularly like to, at the risk of not mentioning everyone, single out a couple of people for thanks. Firstly, Norman Swan for coordinating the panel. It's always a challenge to do so and to land it so well, and you are consummate at it, Norman, so thank you for that. To thank the panel who are put on the spot without notice, and to thank particularly the team in Cancer Services and Information, but particularly Catherine and Emily for the great work they've done in bringing together today's conference. Please remember your evaluation forms. We'd like to know how we can make this better, how we can make it more relevant, and importantly, how we can improve cancer delivery in New South Wales so that outcomes are better. Please enjoy the rest of the afternoon, spend some time networking, and I look forward to seeing you at the Innovations Conference in 2014. Have a great afternoon.